we thought we'd run you through kind of our journey around increasing our projects around availability of naloxone, and we'll talk through a kind of a POP model, given that quite a few forces will be familiar with that concept. So we kind of talk about the issue that we faced here locally, talk about kind of some of the reasons for that, discuss kind of how we responded to that, and then towards the end we'll talk about some of the considerations that some of the force areas and PCC offices may be interested in terms of how they might be able to replicate and expand on their naloxone schemes at a local level. So if I first start talking through kind of our scanning process, we looked at some of the drug-related deaths, both at a local level, a regional and national level. And as you can see here on the slide, the Northeast has had the highest rate of drug misuse for 7 consecutive years compared to all other regions in England. And we can see also that if we look at it across the years as well, there's no surprises that this hasn't just been a short-term issue. So we can see that again, both from a County Durham level, our local levels, to the Northeast, our regional levels, and across the national level, these figures have been increasing over time. And we can see on the graph here that out of the Durham cases, we have had a 126% increase in the last 20 years, and this compares to a 46% increase nationally. So certainly when we're trying to talk about kind of the issue around actually drug-related deaths in our area, we definitely are an outlier compared to the national figures. So I'm not here today to talk about some of the causes of this, and I'm sure all of you will be quite familiar with different reasons for these increases in drug-related deaths, such as an aging population, changes in drug commissioning intentions, changes to the heroin market, but some of them which I thought were quite relevant, which we looked at, are here on the screen, and these might help you when you're starting to build on a local proposal when you're looking at naloxone schemes. So it has been proven, and this is also in the ONS recent figures, that areas which are highly deprived areas have a higher drug-related death. And there's no surprise again that we found that our area in County Durham is ranked in the top 40% most deprived upper tier authorities. We've also got 12% of our local super output areas in the top 10% most deprived areas. And the second one, which I thought was quite relevant for people to look into when building their proposals, was the prevalence of opiate users. So we know that our area has a statistically significantly higher number of opiate users in our population, but also quite a high level of unmet need. So this kind of made us realise that we actually have a high proportion of people who are at high risk of overdose, who actually aren't in treatment, who are at high risk. So again, this is us trying to build a picture around our local population, and actually that there is a need for this response. So when I move into some of the effective responses, I won't talk about some of the long-term responses, but actually one of the ones which you might have heard John Strang talk about last week was in relation to naloxone. So obviously it is one of the most cost-effective and effective responses to drug-related deaths in the short term. So that is what we went and tried to deliver on. We also heard that there's a number of other schemes internationally where naloxone has been used for many, many years before us here in England, such as in the States, which we'll hear more about next week for those of you who'll be attending that one, where they've also got other emergency services such as fire service using it. Other areas across Europe have over the counter. And we heard last week from Steve Taylor that that is being considered locally within Public Health England when they'll go out for consultation around how they can try to expand its use and availability. So the question for us wasn't about knowing how to prevent a preventable death, but actually it was whether or not we had the will locally to implement this. And that is what we set about to do, really. So when we talked about how to answer that question in relation to did we have the will, we needed a commitment both from a local partnership level, but also our top leaders. So back in 2017, coincidentally, on the day that the national drug policy was launched by the government, the PCC for Durham and the Chief Constable agreed a local commitment towards reducing the harms caused by drugs and alcohol. So we had that top cover from the PCC and the Chief Constable in Durham, but we also had a commitment from local partners to deliver on a key objective, which was around this harm reduction approach. Jason and I utilised our expertise amongst our partners here locally. So we were able to draw on our public health colleagues who were able to provide the budgetary support for our scheme. We were also able to draw on the professional procedural support from our public health pharmacists, given that they have had previous work in relation to how to deliver naloxone in the communities. And lastly, we were also able to utilise the professional expertise and training knowledge of our local drug and alcohol service. So again, one of the key things that we would suggest is making sure you have that partnership, because we wouldn't be able to do this scheme if it wasn't with their support, really. And lastly, we were able to receive independent advice from Public Health England. So some of you may have heard from Steve Taylor last week, but certainly having that independent oversight assisted us throughout the way before our launch of our scheme. So that is it from me. I will pass on to Jason Meacham now, who will talk about how we were actually able to implement our vision.
Afternoon, everybody. I'm Jason Meacham, Temporary Chief Inspector in Durham Police. We've been working with Stephanie on this project for several years now. So thank you very much for joining, and thank you for bearing with us whilst we had the little IT glitches earlier on. So I'd like to talk to you about some of the practicalities about how we introduce naloxone into the 3 strands we currently have. So to outline Durham, if you're not familiar with us, we are quite a rural county, northeast of England, just below Newcastle, next to Sunderland. We have 4 major conurbations in our area: Bishop Auckland, Durham City itself, Peterlee and Darlington. They are quite geographically spread around the county. Aside from those 4 major towns, we don't really have any ones of any huge population, and they are the 4 custody sites for our force. So the issue we had, and still have to a large extent, is that at any one time we will only have 2 medical professionals on duty. So whilst we have 4, then we have now 3 custody sites, there's only 2 medical professionals covering them. So they travel around the sites according to need and demand. So at any one time you can see that possibly all of the sites have no medical professional actually with them. That's accentuated by the fact that not only are they travelling, that they also have other responsibilities. They also cover our sexual offence referral centre and attend suspicious deaths in the community, etc. So quite often we have no medical cover in any of our custody sites on call. And that is quite a risk. So during 2018-19, we unfortunately had a spate of overdoses throughout our custody sites. Predominantly these were opiate related, and fortunately none of them were fatal. But I would say a large amount of that was luck, actually. Whilst some of them, the overdoses did occur when we had medical professionals on site, a lot of them happened when we didn't, and our staff had to have that gut-wrenching moment of having to wait for an ambulance to attend while somebody was overdosing in custody, and they had no way of helping other than obviously CPR and things like that. Fortunately, on each and every occasion, the ambulance attended timely and effectively, and they did what they needed to do, and they saved life. But we couldn't keep doing that. We couldn't keep running that risk of an overdose in custody. It was entirely preventable with naloxone. So each and every time either our medical professionals or the ambulance crews attended, they used naloxone, and our staff quite clearly watched this in action. It's a miracle drug. It works very effectively, really simply. And what was critical for our project is that the staff themselves, the custody staff, the detention officers, the custody sergeants, they started to demand naloxone. They didn't understand why they couldn't use this product that was really easy to put together. They've seen the kit put together, and they started to demand of me, being one of the line managers for custody, why can't we have this? If we can't have full-time medical professionals, why can't we have this drug? We need it, we can use it. And that demand from the shop floor, in effect, the front line, the sharp end, was running parallel to Stephanie's world of the partnership approach to try and improve how we dealt with problematic drug issues in our area, wider than this little project. But the two parallel approaches, and for a while I think they didn't actually realise they were both going on. But once we start to get that demand from the custody staff that we need this, and that's when we started to make some good progress. So, massive change. You'd expect a lot of internal consultations between Stephanie and I and a few others. We had weeks and weeks and weeks worth of these things. As you'd expect, the staff representative bodies, the Police Federation and Unison were sort of paramount to this. Our detention officers are all Unison represented if they're in union at all. Obviously, the Federation for the police officers. Tricky would be my honest answer with that. I'm not going to go into the Federation or the Unison angle. You're probably all aware of the stance they take on naloxone, and admittedly, it's a difficult one for them to put across sometimes. But what I would say is beneficial for me, who could see the need for this, was that their own members were demanding this product, and their own members were saying they didn't want to be powerless in the event of an overdose. So I'll come on to a slide in a bit where it goes through some of the obstacles, some of the issues, some of the concerns. But if you're looking to bring naloxone in, obviously those two bodies are your first port of call, Unison and the Fed, and it's useful if you have a representative who's backing you, who's keen, who can see the perspective on this. Obviously, also professional standards, PSLS. And the IOPC were made aware. Certainly internally, professional standards are quite important. Most police forces, you need them to understand what it is you're doing and why you're doing it. They need to understand the legality, which again I'll come on to. Health and safety, quite clearly, needle stick injuries, apart from anything else, risk of transmissible diseases, there's a lot of issues with it. All of those are your key players. But don't forget the people at the front line. The critical. And one other one is the executive of your force. If the executive of your force or the executive of the PCC are behind this and they're driving it, you will get it. And what I would say is the executive, the chief constable at the time and our chief constable now, and the PCC, 101% behind this project, 101% behind getting naloxone into the hands of people that can use it to save life. And that was always the driver for this. Nothing more complicated than that. And if you've got that approach and that person stood behind you saying, just make it happen, you ultimately will. So fear and ignorance. So these were the sort of the issues that we encountered. And on successive slides coming up, I'll go through them one by one. So the legal status was quite a common one. Is it a controlled drug? Is it poisonous? Can I overdose on it? Can cops carry it? You need to get that bottomed. Safety. Is it really tricky? Is it difficult? Can we hurt somebody by giving it to them? Can we cause somebody to overdose? Can you give too much? What if I stab my colleague with it? All sorts of really random but really important questions from people who don't know the answers. You know, cops aren't medics, which is the next one. Training. Cops aren't medics. No. Why are we doing it? What else can we do other than give naloxone? Some of the Federation concerns were, and rightly, were about ambulance response times. Would the fact that an officer was stood with somebody or caring for somebody who'd had an overdose and they had naloxone mean the response times would be downgraded? Would we be left carrying the baby, for want of a better word? Cost, how much? That's another question that got cropped up a lot. And mission creep. So I'll go through all of those for you now. So legal issues. First and foremost, this is the one you need to bottom. And the Public Health England chat we had last week will probably help you with this greatly if you go back and watch the video when it's published. But legal status, is it a controlled drug? Absolutely not. It's a prescription-only medication, naloxone. And legal status, is it fine for officers to use it? Absolutely, 101% it is. So there are three documents I need you to look at, really. Number one, the one at the top there, is the Human Medicines Amendment Act of 2015. This is the piece of legislation or the statutory instrument that enables directly enables the increased availability of naloxone. It allows drug treatment services to supply it to others for, quote, the purpose of saving life in an emergency. That is what you're doing. You are using naloxone to save life in an emergency. So you can be supplied with naloxone by a drug treatment service. Okay. The second one is the one on the left there, Human Medicine Regulations 2012. Again, it's another statutory instrument. This is the piece of legislation that allows the use in an emergency situation of naloxone by persons who have not been prescribed it. So naloxone is quite an unusual drug in that the person who is given it is actually the person that would generally benefit from it. So you can't inject yourself with naloxone. It's quite an unusual drug, an unusual circumstance to get your head around. But section 238 of the Human Medicines Regulations 2012 allows somebody who hasn't been prescribed it to use it for the purpose of saving life in an emergency. So section 238 is the one you want to be looking for there. And thirdly, the document on the right is widening the availability of naloxone from the Public Health England. It comes as a document or it comes as a web page. This one gives some quite clear guidance on the general direction of where the government at the time wanted naloxone to go and what the driver was. It outlined that the widening availability outlined that it was to include any individual working in an environment where there's a risk of an overdose for which naloxone may be useful. I would suggest that a police officer, certainly a police officer in a custody suite, naloxone may well be useful. And that's on the basis of which we've given it to our custody staff. So a lot of the work I've done is trying to make it clear and try to explain to people how simple naloxone is, what it is, how it works, the chemistry of it. It's really complicated, but actually it isn't. It's really straightforward. And of all the hours that I've researched videos and documents, had to try and give somebody a quick idea on it, this is the best video I've ever found. And it's about 3 minutes long. I'm going to play it. It's American, so there are some Americanisms in it, but actually it's really, really simple. And I'd commend this one to anybody, and I'll send the link on the document, but please just watch this a couple of minutes.
Oh, hi, is there audio with this video?
Yes.
You have to select, there's a little tick box. You need to select audio. Tick
Where
box
is it?
so that, it should be on the left. Can you see when you shared it? Bottom left? Somewhere? Tell you what, unshare it and unshare it and then try and share it again. And you should see that little box you tick to include computer audio, I think it is. Can you see it now?
I think we've got it. Hang on 2 secs.
All right.
People are dying every day from opioid overdose. Parents and children, friends and neighbors. But naloxone can help. Naloxone is a safe and effective rescue medication that reverses the effects of opioids and saves lives. To understand how naloxone can stop and reverse the effects of an opioid overdose, it's helpful to see how opioids work in the body. Opioids are agonists. This means they bind to and activate specific receptors in the body, including the brain, brainstem, and spinal cord. When these receptors are activated, people experience the effects produced by opioids, such as pain relief, euphoria, calmness, relaxation, and slowed breathing. Taking too many opioids causes so many receptors to fill and activate that breathing may become dangerously slow and even stop. This is how an opioid overdose happens. And this is where naloxone can help. Naloxone has a strong affinity to opioid receptors, more so than most prescription opioids and heroin. But unlike opioids, naloxone is an antagonist. This means it attaches to opioid receptors without activating them. So when naloxone is administered during an overdose, it knocks the opioids responsible out of the way and allows breathing to normalize. Naloxone can be administered through an injection or a nasal spray. It usually starts working within a few minutes and lasts from 30 to 90 minutes. While one dose of naloxone can reverse an overdose, sometimes multiple doses are needed, especially in cases involving extremely potent opioids like fentanyl, or opioids that stay in the body longer than naloxone. Naloxone is very safe in single or multiple doses. It may produce withdrawal symptoms in people with opioid dependence, but it has no abuse potential and cannot cause an overdose. It's important to remember that naloxone is opioid specific. It has no effect on an overdose caused solely by non-opioid substances like benzodiazepines or alcohol. At the same time, people shouldn't be afraid to use naloxone when the cause of an overdose is unknown. If opioids were not involved in an overdose, it won't cause any harm. If opioids were involved, naloxone can save a life.
So that video, really simple, really straightforward, but really clear and perfect for those people that have an opinion on the topic, but know absolutely nothing about it, which is what you will come across. Everybody will know or have heard of Narcan on the TV, but actually they won't know how it works. They won't understand the limitations of it, the limitations that are good, that it can't overdose on it. It doesn't do anything other than opiates. Really good. I'll send you the link to that if you get in contact with me. Best one I've found by a long shot. So training, that was the next question. How do we train it? I like Larson, so I had to put one of these in. It's definitely not rocket science, this stuff. You do not need to be a rocket scientist to either train or to be trained in naloxone. We use prenoxad 100%. We don't use the Nixoid. I'll go into that. So we're using prenoxad, which is the yellow box, contains a syringe preloaded with naloxone, comes with 2 needles. You unwrap the needle, unwrap the sheath from it, and screw the 2 bits together. And then you find a large muscle mass, top of the thigh, top of the arm, and frankly, you stick it in, you inject it. It's not intravenous, it's intramuscular. You can't miss a large muscle. You go through clothing. You don't have to take people's clothes off. That is it. It's not hard. We have trained way over 200 officers / staff now in how to administer safely naloxone. The only injuries we have had have been staff when they've been trained with little needle stick injuries because they aren't taking it seriously enough. But actually, and that's probably only 2 or 3 people, but actually when we've used it either on the streets or in custody, we've not had 1 injury, rightly so, because maybe with cops, they're paying attention, they're nervous, they're serious, but in a training environment, unfortunately 1 or 2 have a needle stick injury themselves, really, really minor. It's easy to do, it's very straightforward. And remember, this stuff is being trained on the streets. There's peer-to-peer training going on the streets all the time on this product with prenoxad, the needle kit. It doesn't take long. After we ran the initial training of about all of our custody staff, way over 200, and then you're talking about the staff that might provide overtime resilience for us, we were given a training course by Epitharm, the manufacturers of prenoxad. So several of us, myself included, are now train the trainers, so we can train our own staff to administer naloxone, prenoxad. Really straightforward to do. But you've got to get over that misconception that it's complicated. It's just not. So one of the next obstacles that was sort of thrown in our way was the one about ambulance response. and I made the quote up, but effectively goes along the lines of, if the ambulance service knows a patient is with an officer possessing naloxone, the call will get downgraded. Frankly, no, it won't. It absolutely won't. Naloxone is an emergency medication. It temporarily reverses the effect of an overdose. Temporarily is the critical word there, because an ambulance or paramedic or hospital treatment is still required because it's temporary. You can either contact your local ambulance service and get a formal service level agreement with them, which I know one of our neighbouring forces has, or you can go the straightforward route of contacting them, discussing it with them, and they will say the same. It will not get downgraded because it's a temporary fix. Naloxone is not a permanent one. That person still needs help from a professional. What's critical to say, in all of our use of naloxone, we are helping people temporarily. In custody, we're only using it if the medical professional is not on site. If they are on site, they take precedence, we don't get involved. If we happen to be at the scene of an incident where there's an overdose and we have naloxone, we'll use it if an ambulance isn't there. If they get there first, so be it. If we happen to stumble across an overdose, that's when we use it. But it certainly will not downgrade an ambulance response, and the ambulance service will be quite keen to reiterate that to you. But ultimately, if you get an SLA, a service level agreement, it's just a piece of paper. You know, things happen. Cost. That was a weird one, frankly. I'm never too sure, really, should the cost of a life-saving medication actually matter? I never quite got my head around that one. Frankly, if you don't know the cost of naloxone, it's not expensive anyway. The pre-Noxad, the yellow box, is about 18 quid. That has 5 doses of naloxone inside it and 1 syringe. Nixoid is approximately double, it's about £40, and that comes in a box with 2 nasal sprays. The reason we went down the pre-Noxad route was that all of the North East's hospitals, ambulance service, prison, drug treatment services, 100% is covered by pre-Noxad. So it's really straightforward to us to get. Also, we could get the training, we could get the supply, and it's the one everybody around here is really, really familiar with. And at the time of launching our sort of program, Nixoid was relatively new to the market, not easy to get, difficult to get in the volumes. I think circumstances are different now, but it was very new to the market. It was pre-Noxad, is long established and known to be very, very effective and safe. So cost was thrown at me a few times. I didn't quite get it, still don't. Very cheap, not that it comes into it. The additional cost you might come with Nixoid on top of the £40 is that it's quite a bulky item. You're probably going to need a Velcro type packet to put it on your body armor or your belt or in a box. Pre-Noxad comes in a yellow shockproof case, really secure. It is rugged, though it's a syringe is quite hard. It's quite temperature tolerant. Obviously, you think of the people that are having it and looking after it in their own houses. They're not particularly caring for this item. I know cops might do the same on occasion, have it in a glove box of a car, but it is quite a tolerant drug. But that's the way we've gone. Cost for me doesn't really come into it, and that's shouldn't really be a concern. Mission creep was another one that was thrown at me in terms of a reason to not have it. I found that really strange. That was, and I use the word knowingly, this is the worst objection I found actually. Frontline officers wanted this product. Frontline officers had seen it used, they'd seen it work. They were asking me for this product repeatedly. If officers were first at the scene of a fire, they could reasonably do something, they would, and the public would expect them to. If officers were at the scene of a heart attack, first of all, and they were equipped with a defib or they've been CPR trained, they would do something if they could. The public again would expect them to. Our officers, and yours I'm sure, are reasonably frequently first at the scene of an overdose. What's the alternative? They can stand by and watch. They can do CPR for how long? with naloxone, they can save a life quite effectively and safely. What I would say is to people, put yourself in the shoes of those officers who are there looking at somebody overdosing who's overdosed, who wants to help but doesn't have the tools or the equipment. I think our chief in the introductory video calls it part of the officer's toolkit now. It's just another thing we have. It's not mission creep. We're not taking the job of the ambulance crew. If we get there first, we're able to do it. We're not being sent to overdoses instead of the ambulance crews. This is another kit in their toolbox to save life, which from last time I checked is fairly much at the top of our job description. And if you want it any further, Article 2 really places a lot of obligation on us in that respect. So actions and results from our initial sort of rollout. Say over a period of several weeks, we had all of the custody staff, sergeants and detention officers, and both them and the PCs and sergeants who came in to cover on overtime, trained to safely assemble, administer and use naloxone. Initially, that was carried out by local drug treatment services and representatives from Ethypharm, the manufacturers, and they did all of our training for us, and funded by Durham County Council. Supply and distribution, again funded by Durham County Council. Each custody site now has its own stock of naloxone or prenoxad, which again, I say it's only to be used if there's not a medical professional on site. Following that, because obviously there's quite a high turnover of staff, we had the situation where we needed to train new staff quite frequently, so we received train the trainer courses. I've trained dozens and dozens of staff myself. It's easy, we've got the materials, they do the course and they all pass because it's dead simple to use. And we've now way over 200 persons trained to use prenoxad. Since its introduction, it has been used to save life. The first use was actually in the front counter of a police station. A member of the public dragged in their friend who'd overdosed in the street, and her life was saved in the back office, just off reception, by an officer who happened to run into custody, grabbed a naloxone off the shelf and used it. Caught on body cam, brilliant. And we've used it several times now. So such was the success of that, and we'd overcome all the obstacles. We moved on to the take-home naloxone program. Stephanie explained the regional drug issues we have and why we're in the situation we're in. But one of the other things was that we knew a large proportion of drug users didn't go to GPs, they didn't and don't go to drug treatment services. In fact, they don't see themselves as having a problematic drug issue. And maybe they don't, but so because of that, they don't have readily access to naloxone. Unfortunately for some of them, obviously they come into our contact with us, so we saw ourselves as an opportunity to maybe give them naloxone when they couldn't get it elsewhere. So the problem we had with this, because it seemed quite straightforward, dishing it out when people left custody, it was the legal issue. The practicality of it was quite straightforward. So how do we get around that, and what do we do? So the provision of naloxone is controlled by the human regulations, and under existing legislation, the police force is unable to directly supply naloxone. We don't use a PGD, a patient general direction or directive. We took some quite stringent legal guidance on this from our own legal services department, and the county council did the same. It's critical you do that. It's not a clear area. So what we are doing as a force, we are working, for want of a better phrase, on behalf of the county council drug treatment services, and under their direction and control, which is critical, we are supplying naloxone when prisoners are released from custody if they hit certain criteria. To speak generally, that criteria is they're an opiate user, have been an opiate user, or live with an opiate user. It's a bit more specific than that, but that's the broad depth of it. If they hit that criteria and they would like a naloxone kit and they're an adult, we will offer them one. Again, there's a bit of a checklist, but briefly, we will offer them an opportunity to watch our video on what naloxone is and how to administer it. Bearing in mind, if they're opiate users, they'll know how to administer it, but we offer them the opportunity. If they don't want to watch the video, they'll get a kit anyway. As long as it's clear they understand what it is, they can have a kit. And the other sort of requirement on us was that the person issuing the naloxone kit was a trained naloxone user themselves. So all the custody sergeants who are trained to use it are now able to provide it as well for people on release. And there's no strings attached on this. We don't take any personal details other than for standard drugs batch recall. If there'd been a fault with the medication, those details are not passed on to the Durham County Council. But we also supply with an naloxone kit that they walk out the door with a list of local drug treatment services to encourage them to make their own contact. They're not chased up. We also allow this service at the front counters of police stations. So should that person we'd given it to use it, lose it, break it, or it expire, they can come to a station front counter with a custody suite and say, I've lost it, used it, it's broken, and ask for another one, and we will give them one. Dead straightforward, same sort of circumstances. Again, watch the video, please. Sign this piece of paper to say you understand. Really, really straightforward. We've given quite a few away, not as many as I'd hoped. And a lot of that is due to the fact that people go, I've got one already, which is great. I'd actually like them to have two, but they often don't want one. So we're continually trying to push that. But again, it's just another avenue, another option for somebody to take home this medication that can save their life. Now that jumped, so taking you through that. So issuing naloxone, we've actually been doing this quite a while now. And when we did the initial training with custody staff, we trained a few offender management team staff who are in daily contact with drug users in the community and actually gave them their own kit. So actually, we've had a personal issuing naloxone in Durham for quite a long time. It's just not up front and centre. When the COVID pandemic kicked in, there was some changes to the regulations with regard to methadone, and the government loosened the methadone prescription regulation. So you'd have methadone users carrying 2 weeks worth of methadone instead of 1 day's worth. There was quite a fear of a lot of increase in overdoses. That didn't really pan out in our area, but I think there has been issues in others. So on the back of that, we decided that it would be prudent to quickly get naloxone into the hands of frontline cops, who again, because as I said, they get to those incidents quite quickly, they're quite often first at the scene. So in conjunction with the council, they agreed that the medication I had in our possession for take-home naloxone to be sort of pushed sideways and given out to staff. It's the same product, it's just a different use. Really, really quick, one email, and 2 minutes later it was approved. And then that proves the relationship, really, if you can get it, of a good relationship with the county council public health team. I don't know if they're on this audience in the background, but really, really supportive. We're on the same page with it. We're here to save life. There's no political score in this. So we quickly got it into the hands of those staff that were frontline, that were already trained to use it. So all those custody staff that had left custody, they'd already been trained, so I gave them one. All those PCs and sergeants who sometimes do overtime in custody, but actually the main job is frontline, I just put one in the hand because they're trained already. And then we made a concerted effort to train those real frontline officers, those ones on the traffic or road policing units who tend to get those incidents first and tend to be slightly higher trained, although that wasn't really a requirement, and got them quickly trained. So we approximately 60 plus persons walking around the county now with their own personal issuing naloxone kit. And again, that's been used probably 4 or 5 times now. First one was at about 3 o'clock in the morning in a village in the middle of nowhere in County Durham, a young lady who was overdosing, and it's been used no end of times now. Really, really effective. So that's the end of that section, really. What I would say is, of all the things I've done in my 26, 27-year career, this is by far the most worthwhile and beneficial. Really, really push it, take advantage of it. And I know there's plenty of other forces doing this now, and we all do it slightly differently. Some forces take a really academic approach to it, and a lot of studies and a lot of trials. We haven't. The efficacy of the product is so clear, we didn't do that, but that was very much down to the approach of our exec at the time and the PCC here, and maybe some forces can do that. The benefits and efficacy of this is clear. Just do it, but do it whichever way you need to. So some considerations for replication. 24/7 in police custody. You might not need it. If you've got full embedded healthcare, you just won't need it. Staff views. If you have staff who are advocates of this stuff, if they've been an ex-paramedic or ex-forces or an ex-drug user or family drug user, get them on board, because they will be an advocate for change. We've got a few in our force who are dead vociferous for this, and they're beneficial. If you're having issues with organisations or representatives saying staff don't want it, get these people on board. Training, it's not hard, it's really not. I now train people in an hour, just over an hour, to how to use it. It's dead easy. Speak to your public health team, speak to FETHARM or the manufacturers of Nixoid, get the training materials. They're all online anyway. You can go and see all the videos. That makes it part of our training. Funding very much depends on your PCC. Ours is partnership funded, but actually, if it wasn't, we would just do it. We'd find a way. It's not a lot of money. Admittedly, if you're 5,000 cops in your force and you're looking at personal issue, it's a bit more, but actually in the scheme of things, it's not. PGD or service SLA, again, that really depends on your PCC's office. If the PCC is funding it, I think you need a PGD. You need to have a quick look at that. What I would say is the legal stance in this area is blurred, would be the best word. We certainly as a force of the take-home naloxone are now doing things that probably the legislation and the guidance didn't expect. And having taken advice from Public Health England, it's clear that probably the next round of guidance will encompass what we're now doing and make it explicitly clear. But certainly when the guidance was published 10 years ago, however, they weren't expecting people to be doing what we're doing. Prenoxad and Nixoid. I explained why we took Prenoxad. Dead simple to use, proven, rugged, suitable for police officers to use. And at the time, Nixoid wasn't that new. Was new and not that available. Nixoid certainly has benefits in that you don't need to put a needle kit together. There's less risk of stabbing yourself. There's less risk of needle stick injuries, full stop. What I would say is also, if you use Nixoid, you're putting your hand next to somebody's mouth with some teeth in it, will be the other angle on that, and that's been mentioned to me, so it works both ways. Ambulance service agreement, absolutely. If you don't have an SLA, you at least need to speak to them. I really don't think that's as complicated as people make it out to be. You can go the full hog and have an SLA, but just have that conversation. Rurality. We're a really rural force. Our road network isn't great. Our response time to some of the outlying areas won't be what they are in town city centres. I think if you're a rural force, there's a massive benefit for having your cops, either personal issue cop or personal issue for the vehicle. I know having stock in vehicles means check sheets and whatnot, but absolutely some benefits there. So really, that's it from me and Stephanie, or Stephanie and I. Any questions?
Thanks so much, Stephanie and Jason, for that presentation. It's really interesting to hear your first-hand perspective on implementing these programs. And just a reminder to everyone that you can submit a comment or a question if you click the icon with the speech bubbles and question mark at the top of the team screen, and we will put them to Jason and Stephanie. We just have a few other questions coming through. One was about if this program has had any impact on your relationships with these partners, you know, how they if they were sort of already well-established networks before these programs, and if it's led to other programs being developed.
I think from my angle, feedback there. That's better. Yeah, I think from my angle, we had good relationships with our public health team anyway, but actually what this has done is brought a real group together much closer. We're now on first name terms with the drug treatment services, the healthcare services, and really helpful. That sharing of knowledge is much deeper and quicker now, that we get emails on things such as Hep C testing that might be considered, that we're now looking at, that we never would have before, or that it wouldn't have trickled down to us from higher levels. It comes to us directly. So really much more of a team effort now. Even though they're an external organisation, we get a lot more team approach. It's really beneficial. But I guess that depends on your relationship with your council. We are quite close and we work quite closely together. We do have 2 councils within our policing area. Not unusual, but it does make life difficult. Durham County Council is by far the bigger partner there. Darlington Council is quite a small one, but we've made sure that Durham County Council are more than happy to sort of cover the area that actually they're not legally responsible for. Stephanie, any input on that?
Yeah, and I guess the other thing to note is that the police naloxone program is part of a wider partnership naloxone program. So there's been previous work before us in relation to increasing the availability from prison releases, from pharmacists within the community and the community drug and alcohol service itself. So I think that also led us to having wider support from our partners as well.
A sort of related question, whether which messages partners in terms of engaging with them were most effective, or if it wasn't really sort of necessary to find, you know, those kinds of messages.
I think, as I mentioned, we had obviously a key objective which was shared amongst partners. So we did produce partner briefings to make sure that everyone had the same kind of messaging, but we didn't really need to do it really because we'd all been working previously around kind of how do we reduce the harm caused by drugs anyway. So we already had that commitment. I think, I don't know, is there anything else that you would like to add, Jason? No? Yeah.
Great, thanks for that. And a question about how to effectively maintain lines of communications with partners. You know, as these programs are implemented, if it's important to sort of regularly update or catch up with partners about how implementation is proceeding.
Yes, I mean, in terms of our kind of monitoring arrangements, given that it is funded by the local authority, we did have monthly meetings to begin with, making sure that everyone was happy with progress on it. But now it's just embedded within our wider drug and alcohol partnership group meetings. So we don't have any kind of standalone task and finish groups or anything for it, but it's just part of the wider partnership approach to reduce the harm caused by drugs.
Yeah, I think to add to that, it's daily business now. None of this is unusual. Even when we now use naloxone, it's daily business. It's not something that people go, oh wow, how did it go? It's not of any great interest, which is a brilliant development that is so normal. But the relationship with the council, critical to be open and honest with them and what you're looking for here. Initially at the start, a lot of meetings, there was a core group of probably only 5 or 6 of us that needed to be involved. You need to get the right people with the funding, people with the authority, and people with the ability to go yay or nay quite quickly without having to go upstairs all the time, from all partners, including ourselves. And certainly from Durham Police, I was given almost a carte blanche to make it happen along with Stephanie. And that's the approach you need with the council, getting somebody who wants that same objective. But once it's become embedded, we rarely communicate other than, like I said, oh, there's a COVID pandemic. Can we use your naloxone? Absolutely, you can, just get on with it. And I knew they would say yes, because I know them so well now, but it's a common courtesy to ask permission. So no, once it's up and running, it's like any other partnership. I think it's fine. We all wanted the same thing.
Sorry, I was on mute then. So I have another question about relationship building. The question is, have relationships between police and the public, particularly people who use drugs, improved through the carriage of naloxone?
Tricky one to say. All I would say is that every piece of media we've had on this, whether that's me appearing on TV, on ITV News several times, on BBC Crime Watch, on BBC Radio, on all the local newspapers, it's always been overwhelmingly positive. We've not had one negative sort of question. Social media, it's a mixed bag, as you'd expect. There's people take very strange perspectives on it, but overwhelmingly, so if you speak to the drug treatment services, they're astounded. I had an email recently from the manufacturers of the product, and they are staggered of where we've taken it from using it to actually giving it away to people. That was way outside their expectations. And what I would say is about Epipharm, it's a lost leader. They don't make any profit out of this drug. It's handmade in a factory in England, so they don't make any money out of it. It's almost their charitable donation almost. No, I've not seen any negative public feedback on our relationship and what we're doing here with naloxone.
Great. And another question, have you experienced any resistance? And if so, how did you tackle this?
So the only resistance really was at the very start of the process, and a lot of that was the fear and ignorance really, particularly around the legality, which I understand, being who we are, we need to be on the right side of the law, but equally we need to be seen to doing the right thing, and sometimes the right thing might not necessarily be within the letter of, but actually with this circumstance it is. It's perfectly legal, but people needed to understand that and see it, and because it's falls outside our normal working practices or it used to, I had those questions about, is it a controlled drug? So really random question, but really critical. Of course it's not. How do you know it's not? So those are the challenges we had. The main sort of challenges, obstacles you will find will be from the representative bodies, because they are protecting their members and they have worries about litigation, again legality, and again injuries. And I suppose they're protecting their members, but equally there's the other side as well, that their members are in a position of having to do something about an overdose in front of them. So those were the main ones, and they were right at the start. As soon as we got it embedded, the take-home naloxone program, absolutely zero objections to it, not one from anybody. One or two raised eyebrows, because it was so novel and unusual, but no objections. From personal issue, not really, no. It was that initial introduction because it was new, and obviously the National Police Federation stance on it is problematic from the perspective we've been trying to do.
Great, thanks. I have a question about your plans for the future, if you're planning to expand the naloxone programming or offer.
So in terms of plan for the future, at the minute, we are where we are. We use it in custody when we have to, and there's not a medic there. We are currently in the process of building a new custody site, which will have embedded 24/7 medical care. So ultimately, in a couple of years' time, I don't envisage custody staff having to use naloxone. In terms of giving it away from custody, that needs a bit of a further push, but that's not a change. That's just, it needs progression. I guess the question probably is aiming at the personal possession front line. At the minute, there are no plans to roll it out any further. We've got staff and officers who work in custody having personal issue. We've got frontline police officers who are sort of fast line response issued with it, and at the minute that's where we are with it. And obviously those people, the issue of policing is like many jobs, people move roles. So what you'll find is that PC Smith, who used to work in custody, is now on dog section or neighbourhood policing, so he or she takes that naloxone with them. So quite quickly naloxone becomes very commonplace amongst the organisation, even though that was never the intention. If they move roles, we are not taking the naloxone kit off them. That kit goes with them because they're experienced in the training and the kit goes with them. But know that there is no proactive approach at the minute to take it any further. Stephanie?
Yeah, so we hope that by word of mouth amongst the kind of drug using population, there'll be an increase in terms of the take up and a lot more confidence and trust that actually they could walk up to the front counter of a police station and ask for it. The other development that we are looking at, which has been agreed now, is the move from peroxide to the Nixoid as well. So again, that was through funding from our public health teams locally. So we will now be able to transition that. So when police officers on the front line have to come back into kind of replace their kits, we'll be able to actually offer them Nixoid rather than the peroxide, which is what they currently have.
Great, thank you, Stephanie. And just to let all the attendees know that unfortunately we've had some technical issues with ACC Richie's presentation, so we I think we'll have to reschedule that, unfortunately. And we have just a couple of questions left, so if anyone would like to submit a question or a comment now, you can go ahead and do so. So the last question I have is about the take-home naloxone that is offered to people leaving custody. And there's a question about if anything else is done in terms of referring these individuals to other services or other forms of support once they leave custody.
Yeah, Jason can probably add to this one, but I guess in terms of our case, it's important to note that it is a voluntary scheme as well. So actually, if they don't want it at this moment in time, they are not forced to have it. We may be looking at whether or not that's an option to have it as an opt-out rather than opt-in process. But certainly in terms of encouraging them to go to drug and alcohol services afterwards, they will be given their contact details. But at this moment in time, it wouldn't be a forced move, really, as it's up to the individuals. But Jason might talk about a bit about what currently is happening.
So yeah, say I manage the custody suite. So within the custody suites, you would expect, and I would expect, anybody who's got a problematic drug use to be spoken to or with by the medic. And that's fairly routine, and that'll be looking after their needs whilst they're in custody. They also routinely have access to liaison and diversion for sort of mental health, drugs, alcohol, longer term issues, withdrawal or whatever. So the provision of naloxone sort of falls outside that. As Stephanie said, it's purely voluntary. My staff are told to offer it to the person at any point in their custody stay, but actually it's sometimes beneficial to do it just before they leave. So no, it's purely voluntary. It's non-problematic. It goes alongside everything else. There are no strings, no conditions. I know some forces do give naloxone away in custody, but it tends to be the FME, the doctor, that does so. Again, we can't do that overwhelmingly because we don't always have a doctor or a nurse in custody. So that's why we're doing it the way we're doing it. If circumstances were different, we may take the doctor-led approach. But it's quite straightforward to ask a police officer who's trained to use naloxone to follow a spreadsheet, ask the questions, tick the boxes, and give it away. Really easy, and people get it.
Great, and I had another question about if there is an expiry date on naloxone, or how long does it last?
There is, yes. It's generally 2 to 3 years off the top of my head. So we obviously keep a track of all our naloxone. When it gets to about 6 months near to the expiry date, which we're actually coming up now on some of ours, the agreement we have with the county council is that we'll bring it all back in. They'll give us some more, and we'll give some new stuff out. The old stuff, because it's got 6 months left on it, what happens is it'll be given to drug treatment services to use because their throughput is much higher, and they'll get it back on the streets much quicker than we ever do. It like any medication, it doesn't suddenly stop working at midnight on the expiry date. It certainly doesn't do any harm. What happens with naloxone is that it becomes slightly less effective as you go on, and it might need 1.1 dose as opposed to 1 dose, or 2 doses as opposed to 1 dose over a period of time. It just becomes slightly weaker. So there is no problem giving it a day after expiry, but clearly we'd rather not do that. So we have plans in place to bring it all back in close to expiry date and give new stuff out.
Great. So that's the end of the questions, and apologies again for being unable to share ACC Richie's presentation today, but we will get back in touch with you all about hopefully rescheduling that soon. But for now, thank you so much to Jason and Stephanie for your presentation, and yeah, we'll be back in touch with you all. Hopefully, we'll see you at the at next week's presentation on the 24th of May on evidence on naloxone programs from the United States. Okay, thanks so much.
Thank you.